And welcome everyone to this International CML Foundation's key discussion on CML Latin America, where we will kick off this season with a debate on first-line therapy. Is imatinib still the best frontline treatment? I'm Arlene, I'll be your moderator today, and before I introduce our expert teams, I'll just take a moment to tell you, the newcomers to the Foundation, a bit about who we are and what we do. So we are a physician and researcher-based organization seeking to share CML expertise globally. We do that through CML education via our case discussion forum, conversations like this one, the Knowledge Center, and highlighting significant papers and conference summaries for people who are unable to attend in person. Over the past 15 years, the Foundation has been working via preceptorships, in-person meetings, country-specific and regional discussion groups like this one, trying to make sure that no matter where in the world you live, CML physicians and researchers have access to the very best possible knowledge, opinions, and expertise. The other side of our work is harnessing the power of global research. Our ideal is working towards a cure for CML, but along the way, we're trying to improve treatment pathways and patient outcomes as much as possible. So we have the Genomics Alliance, the TFR Alliance, we did lots of work around CML and COVID, a hepatitis B survey of practice, and we have just embarked on a pediatric CML study, which should culminate in developing treatment recommendations for low and middle income countries, and lots more to come. So that's a brief overview of the International CML Foundation, who we are and what we do. Please reach out to me if you have any questions or want to know more about our programs. Okay, so our debate today addresses the proposition: first-line therapy, is imatinib still the best frontline treatment? This is a really important topic. It's an active area of debate between practitioners. So we thought we'd do just have that. We'll have a debate, but we'll also try and have a bit of fun in our approach to discussing such an important topic. So we have pitted some of our very best minds against each other. Let's see how they go. So it's my great pleasure to introduce the team speaking in favor of the proposition. And our regional expert is Dr. Katia Pagnano from Campinas in Brazil. So not only is Katia a great physician, she is an intrepid adventurer. She has summited Mount Kilimanjaro in Tanzania, climbed to Annapurna Base Camp in Nepal, and successfully took on the Avenue of the Volcanoes in Ecuador just this last month, all to raise funds for CML research and physician support through the ICMLF Climb for a Cure program. She is a tough cookie, and I'd rather be on her side of an argument than the other side. So welcome, Katia. Lovely to have you here. Our international expert in favor of imatinib still being the best frontline treatment is Professor Ehab Atallah from Milwaukee in the USA. Now, along with Katia, I spent a week or so with Ehab climbing for a cure in Nepal, and some of my favorite memories are of us hanging out at the back of the walk-in train, debating the rights and wrongs of American politics. Now, I think as an Australian, I held my own, but Professor Atallah demonstrated a willingness to defend the indefensible in that context. So let's see what he brings to the floor today. Welcome, Ehab. Such an honor to have you here. So our regional expert against the proposition that imatinib remains the best frontline treatment is Dr. Virginia Abello Polo from Colombia. She is a great physician and researcher, an ICMLF Key Discussions alumni, and a member of the Foundation's Latin American Steering Group. Virginia stepped in and saved the day at our very first CML debate when our original speaker became unavailable. And even with such a short period to prepare, she showed herself to be a formidable adversary. And I'm delighted that she is here today. Welcome, Virginia. And finally, our international expert against the proposition was supposed to be Professor Tim Hughes from Australia, but his flights fell victim to current global events, and he's currently in the skies trying to tune in via in-flight Wi-Fi, or either that, or he just wasn't up to taking on Ehab and Katia. However, we're very fortunate that Professor Giuseppe Saglio from Turin in Italy, who is the champion of our knowledge centre, has stepped in at the last minute. It's actually 1 o'clock in the morning for Beppe, and I think he's forfeited a night out at his favourite club to be here. So you already have lots of points on the board for that already. Welcome, Beppe. So let me tell you how the program will roll out today. We'll start with Katia and Ehab talking in favour of Imatinib still being the best frontline treatment. Then Virginia and Beppe will argue that there are often better choices than Imatinib for frontline treatment. Then we'll invite rebuttals, questions and comments, firstly between the experts themselves, and then open up quickly to all of you, the audience. So Katia, would you please take the lead by loading your slides and telling us why Imatinib remains the best frontline therapy?
Can you see it, Eileen? Yes? Is that okay? Can you hear me? Okay.
Perfect.
Okay. Hello, everybody. Thank you, Eileen, for the very nice introduction. I'm very glad to be here among friends to discuss this important topic. This part will be me and Ehab are going to talk about the longer-term experience with Imatinib and compare Imatinib and the second generation TKIs, and also Imatinib and Asciminib. So to start, you all know that Imatinib was developed in the 90s, and in 1998 it was the first clinical trial. And finally, in 2001, FDA approved Imatinib in USA to be used after interferon failure, and in the next year for first line. So we have 25 years of TKI now, and later Dasatinib, Nilotinib, and Bosutinib were approved in the first line treatment, and in 2024, Asciminib in first line. And during these 25 years, the goals of frontline therapy in CML have changed, because now at the beginning we just wanted to improve overall survival, and now we have overall survival similar to the general population. But we also aim now to increase the rate of stable deep molecular response, because we want our patients to have higher chances of successful treatment-free remission. The picture on the right, it's the Kilimanjaro mountain in the Climb for a Cure 2019. And I'm using this picture as an analogy for the CML challenge that patients have during the life to achieve a deep molecular response, fight to try TFR, but we know that it's very difficult steps to get there, and not so many patients will get free of medications. And for these particular patients, we need to reduce early and late toxicities to have better tolerance of the treatment. And we also want that every patient in the world have access to all drugs to improve the chances. So when we select the frontline TKI treatment, we have to consider many different scenarios. We have to consider the aim of the therapy, the toxicity profile of the drugs, patient comorbidities, and also cost and affordability of the drugs. These pictures are of 3 important clinical trials, phase 3 clinical trials, that compare the Imatinib with second generation TKIs in the first line. So we have NSND for Nilotinib, Decision for Dasatinib, and before for Bosutinib. What we can see in common that Imatinib, the rate of major deep molecular response with Imatinib is around 30 to 35% in 5 years, and all the others second generation TKIs, they have an increased rate of deep molecular response. 50% with Nilotinib, Decision, and Bosutinib in the first line. We also have an important predictor of achieving deep molecular response, that is the early molecular response. In figure A, you can see that if you reach MMR by 3 months, the chance of achieving MMR 5.5 later is very high. However, if the patient, in figure G, if the patient doesn't achieve major molecular response by 18 months of treatment, practically there is no chance of achieving deep molecular response in the future, so this patient will not be successful in TFR using Imatinib. This patient will have to change treatment. Despite the the faster and deeper molecular response with second-generation TKIs, it doesn't change in terms of overall survival. You can see that all the curves are equal in nilotinib, dasatinib, and bosutinib in first line. And in the Latin America experience, this is not different. On the left, it's a work conducted in Colombia. And we see that in 5 years, the overall survival with imatinib treatment in first line is 97%. And also in the long term, it remains above 80%. The same in another Brazilian study that we have 86% at 6 months, at 5 years with imatinib in first line. The Australian group showed that the eligibility for TFR is higher in patients treated with second-generation TKIs. So we see here imatinib 52% of chance of achieving eligibility and 65% in frontline second-generation TKI. What about toxicity and about patient comorbidities? How those conditions help us to select the best frontline treatment? In this very busy table, we see all 4 inhibitors approved in first line, and the adverse events, most common side effects related to TKI. For example, dasatinib everybody knows that it causes pleural effusion, so a patient with a pulmonary comorbidity will not use dasatinib as first choice of treatment. And the same with nilotinib. If you have a cardiovascular condition, if you have pancreatic disease historic, you're not using nilotinib in first line, and the same for bosutinib for gastrointestinal conditions. So combining patient comorbidities and the drug toxicity profile can also help us to choose the best choice in first line. Imatinib is very safe in terms of cardiovascular events, but we have many adverse events at long term, grade 1 to 4, 76%, and 22% of grade 3 and 4 events. And the most frequent events that we know is fluid retention, edema, gastrointestinal problems, muscle and joint pain, skin rashes, fatigue. So no drug is perfect. So we have to consider to balance risk and benefit when you are choosing your TKI. This is a work that we did many years ago in my center, evaluating the cardiovascular and arterial events with the TKIs we had available in Brazil, and we saw that we have a higher rate of cardiovascular events and arterial events with nilotinib compared to imatinib. And another topic that will be discussed also in Ehab's presentation is the cost and affordability. This table is just to show you that the price of different TKIs may vary depending on the country, and also the same drug in different countries have different price. For example, the generic imatinib in Sweden is 184, and in Italy, 12,000. And also the prices of second-generation TKIs and asciminib and other ponatinib and other drugs, they're more expensive in USA than other countries. So this is a very tough topic, but it's essential for different countries to have available the different medications. So to illustrate the long-term follow-up of patients that are using imatinib from a long time, I'm telling you a case of a 43-year-old woman at CML diagnosis in 1998. This time was before TKI. At that time, she was a low so-called risk, had no comorbidities, conventional cytogenetics and BCR-ABL transcript, and she was treated initially with Hydrea and after interferon alpha, and then imatinib was available only in 2004. This patient was very successful in her treatment. She had a good tolerance, no severe adverse events. She had an early response, complete cytogenetic response in 6 months. She had a major molecular response in 15 months, and she was able to achieve a deep molecular response. And she entered in a clinical trial. In 2018, she stopped imatinib after using for 14 years the treatment. And she had a small decrease in the baseline creatinine. That's something that imatinib does at long term to impair the renal function. And after discontinuation, now she has 8 years of TFR, and she remains with undetectable PCR. This is the trial that this patient participated. It's a small phase 2 trial, but we identified that in this study, low-risk patients and patients that were treated for more than 9 years had the best TFR chance, around 80%. So this patient was very lucky to achieve this, and now she's doing fine. So just to make my point, what can happen in 25 years? Now, you know, Imatinib is now 25 years. What I did in 25 years, I married, I had a baby in 2000, and now this baby is 25. And in this time I worked, I raised my family. And during this time, we treated lots of CML patients that we can see here in this graphic that survived just like us. And those patients that 20 years have 77% of survival, they are still here, and they were able to do the same as I did in all those years. And so that's why I think Imatinib is still a good option for the first line. We have a longer follow-up, we have a safe cardiovascular profile, and we have a long-term survival similar to the general population, and also a large experience in successful TFR in those patients. And so far is still the most cost-effective treatment. I'd like to thank you, and I'd like to pass the stage for Ehab. Thank you.
Thank you, Katia.
Thank
Some
you.
compelling arguments there. Ehab.
So hello everyone. I'll try this. Agora voleje contar a verdad. How about that? I hope I got it right. And then in Spanish, ahora te diré la verdad. And if I butchered that, you can blame Katia. So I will share my screen. And mainly I will talk about can you see my screen? Am I good? Yeah.
Yes.
Okay.
All good.
So these are my conflicts of interest. So what we're really discussing today is really the battle of the nibs, right? So it used to be dasatinib versus imatinib, nilotinib, bosutinib. Now our battle of the nibs has really, really added to it asciminib. And what's crazy now is that our battle of the nibs has even extended beyond that by having dasatinib, having generic dasatinib, having generic imatinib, having dasatinib that doesn't need PPI, having nilotinib that doesn't need food. And you see these little guys at the end, that's not a mistake. These are a bunch of newer TKIs that are coming in. So the battle of the nibs has really, really increased. And that's our job, is to figure out what are we going to do with all these medications. So I'll just reiterate some of the things that Katia talked about, and I'll filibuster and fill up the whole hour. So Beppe and Virginia, they do not have any chance to talk. I'm kidding. So what I'll talk about mainly is comparing generic imatinib with asciminib. So there's these four statements. Patients on asciminib are more likely to get to a treatment-free remission. Asciminib is a safer drug in the short term. Asciminib is a safer drug in the long term, and you get what you pay for. So a little bit of what Katia talked about, I'll just give it a little more detail. So patients on asciminib are more likely to get to a TFR. Is that a true statement? So across the years, there have been multiple studies. These are all the different studies with more than 2,000 patients enrolled, including imatinib, dasatinib, nilotinib. Yes, I did spend a lot of time making this slide, so I have to use it whenever I can. So that's just a lot of patients there, right? So we have a lot of data there. I'll show you the data for asciminib stopping studies. Yep, that is it. This is the data for asciminib stopping studies. Nothing. We have 0 asciminib stopping studies to this date. So even if we say that asciminib will get people to more TFR, we don't actually know that. Second statement, asciminib is a safer drug in the short term. Katia showed you some of the data from her institution. I'll show you the ask for first data. So the ask for first data was a randomization of asciminib versus any choice TKI. what this table shows you, ignore kind of the whole table, but look at the bottom there. Patients who were randomized to imatinib were older and had higher cardiovascular risk disease. So two things: older patients on imatinib, higher cardiovascular disease. And let me show you the cardiovascular side effects with imatinib. Zeros. You can't beat that. So remember, these are patients who are older and have higher cardiovascular disease, and imatinib, zero. Almost imatinib is cardioprotective, you could say that. So you can't really beat a zero in terms of cardiovascular effects. Asciminib, the other statement is asciminib is a safer drug in the long term. Really, you compare, this is data of 25 years of follow-up for imatinib, right? Look how long this is. Asciminib follow-up is that line that's over there. Only 24 months, 48 months for frontline at best. So we have a very, very short follow-up for asciminib compared to imatinib with how long follow-up we have. Lastly, it's important to talk about cost. Katia showed you some of the numbers of cost. This is mind-blowing. To us in the US, imatinib is $600. You buy groceries for that because groceries are pretty expensive now. Asciminib is $300,000. You buy a car and a house for $300,000. That's the difference in the price between generic imatinib and asciminib. So is it worth it? Is it worth that humongous difference? So there's something called ICER, which is incremental cost effectiveness. And I'll just walk you through this. Just give me 5 minutes of your time here. So if you're comparing two drugs, drug A costs $50,000 and results to an improvement of five quality life years. Drug B is more expensive, $100,000, but results in a quality of life or a response rate of 7. So the incremental cost between the two drugs, so drug B is more effective, but it's more expensive. So the incremental cost between $100,000 and $50,000 is $50,000. The incremental effectiveness is 2, 7 minus 5. So in this case, the ICER for this drug, or the incremental cost effectiveness for this drug, is about $25,000. Okay? So let's apply this to imatinib and asciminib. So the incremental cost is $300,000 minus $600, that's $299,400. The incremental effectiveness, I'm assuming, being generous, that the difference in response is 40% versus 70% if getting into a deep remission, which is 0.3, which means you would spend $998,000 per additional responder per year, almost $1 million per additional responder per year. That's called ICER. The acceptable ICER across nations is about 100,000. This is 10 times that. So a really expensive drug. The second question is, well, if we get more people to TFR, that would be good, okay? So walk through this with me. So you have 100 patients over 5 years. They will cost $300,000. 30 of them achieve MR4, 15 achieve TFR on imatinib, right? Because only half of them are successful. Another 5 years, so over 10 years, your cost is about $500,000 for patients on imatinib. We'll look at asciminib. You have 100 patients. Your 5-year cost is $150 million. 60 achieve MR4. Half of them will be successful. Another 5 years, that's another $105 million, which means your overall cost is $255 million compared to $500,000 for asciminib versus generic imatinib. Huge difference. So then if you do the math, it will cost you about $25 million to stop an extra 15 patients, which is about $16 million for extra patient stopping. So the cost is really significant, even if we assume that asciminib gets more people to a more TFR. Again, this applies to the US. You do your numbers. I think they will be less than that, but still the cost would be pretty significant. So the question is it really worth it to spend that much to get to 1 TFR? And finally, it doesn't. These are all important questions. At the end of the day, we're very fortunate to have all of these choices, because at the end of the day, about 40% of patients switch their first-line therapy. And that's something it's really important for us to tell our patients and to know, like to tell our patients, you know what, if we start you, whatever we start you on today, there's a really good chance that we would switch you. So at the end of the day, these are important conversations, but a lot of patients will switch anyway. So thank you very much. And I would like to hear the other side.
Thank you very much, Ehab. Thank you, Katia. There are some very compelling arguments in there. Is it worth it? So, Virginia, would you please load up your slides and tell us why there are often better choices than imatinib for first-line treatment? When is it worth it?
First, I have to say that Ehab knows that doctors are very bad at math. So he just confused us with all those numbers. So we get lost, but I'm going to prove you wrong, okay? That's a very smart way to go. Use your numbers. All of us were there trying to do the numbers, the math on that. Okay. So it's easier to talk about patients when you already were, successful with the imatinib in first line. But it's not easy when you have a patient, on your side, in front of you, and you have to tell him, I'm going to use imatinib on you, even if there's, better options now. So that's why I'm going to start with two cases, and these are very different cases. One is one case, one scenario is a 34 years old woman, no comorbidities, chronic phase CML, ELTS, intermediate risk, wishes to have pregnancy sometimes, and she's in a private setting, For Latin America, at least, this makes a big difference. And then the other case is a 65-year-old male, well-controlled hypertension and diabetes, chronic phase CML, ETLS, high risk, and he's in a public setting, which is, completely different, and we have to take it in account. So these are the new guidelines from the European Leukemia Net recommendation, and they're very interesting. If you haven't read it, they're interesting because they change the scenario. We already know we can have these patients with CML living as long as well will do. The life expectancy is well, but now we want to go try to take them to TFR. While this is a laudable goal, we also recognize that the patients will remain on lifelong medication, a lot of them. So for them, optimizing both their responses and their quality of life is paramount. So we want to take them to TFR, but with a good quality of life. So this is the same data that Katia used. We all know that we had imatinib, which was good for a time, and then we compare it with second generation TKIs and all of them showed us that the treatment goal, if you want to get to TFR, you will get deeper responses with all of them. With Decision, with the NES, all of them will do that, but this has a cost. They will all get you to a faster molecular response, and which is nice if you're trying to go to TFR. Sorry, this is not passing. Wait. So there's the price to be paid on that. We all know that with second generation TKIs, all of them will have more cardiovascular events. All of them will have more toxicity. And this is what happens in real life. Katia showed some information about this publication we made with our group in Colombia over 20 years. And what we can see here is this is imatinib in first line, because of course there's a large cohort of patients during 20 years in Colombia. And what we can see is 79% of the patients treated with imatinib in first line will end up changing lines to second line, third line, fourth line. So most of them by resistance. Nilotinib, only 19% of the patients, the whole cohort, changed it to a second line treatment. Most of them equally for intolerance and resistance. And dasatinib, 29% of them changed lines, 60% due to intolerance, most of these patients. So if you start patients with imatinib, they will end up changing lines of treatment. And a lot of them will have resistance, which is not good for patients. Of course, these patients will not go to TFR. And a high proportion of patients will be changed by intolerance. So this is not an ideal start. So if you have a patient and you start saying 70% of the times you will be changed, maybe that's not the best thing. And so we have a drug which is highly effective, but slow response, slow molecular response, and less TFR. We all know that. And then there's the second generation of TKIs, rapid response, but high toxicity. So the price to pay in terms, not in terms of money, but in terms of quality of life and toxicity may not be, enough. So what if we could change this classical paradigm to be changed? At the end, they all will live like a normal life, but we want them to go to TFR without so many distress and toxicity. So this is as for first, asciminib versus all standard TKIs in newly diagnosed CML. This is the design, we all know about it. So what's interesting here is the molecular response at 96 months. You can see the change. This is asciminib, this is all our TKIs. This is molecular response 4 and molecular response 5, which we all know will predict how many patients will go into TFR. So this is very fast response, which is good. We have seen this before also, with second generation TKI, but look at this with this comparing with imatinib. If you have asciminib here and imatinib here, you can see the difference, not so much for the second generation TKIs. But then you go through this is the benefits of asciminib or imatinib. It is evident in every group you put it. And then you again go to the safety profile, because of course they're gonna be alive anyways with imatinib or with asciminib. But what about the quality of life and what about the adverse events? So this is asciminib, 44%, grade 2, more than grade 3 adverse events, 44%, imatinib 49%, which is higher, and second generation TKI is 60% almost. And what about discontinuations? Only 5% of patients discontinued due to adverse events in asciminib, less than half of the patients. So this is significant. This is, it makes, if you have to take the drug and you're the one seeing this data, you wouldn't want to be in which arm will you want to be. So this is the same idea that Carla talked about. So what about toxicity profile? Imatinib is better, well tolerated, of course, than second generation TKIs, especially in cardiovascular risk event. And this may not be the case for asciminib. So in that case, in the first patient, of course, we would want asciminib or a second generation TKI if we can have it. Definitely for the patient with hypertension and diabetes, if you want a profound response, we would like to have asciminib. Then the aim of therapy, TFR should be the goal of most patients. If you are newly diagnosed patients, you would want to suspend your drug sometimes. Nobody wants to be forever in a medicine. So especially for younger patients who wish to have cureness. So second generation TKI are better than imatinib in this scenario, and asciminib also is better than imatinib. So for case 1 and case 2, we would not want imatinib. Imatinib won't be preferred in these cases. What about comorbidities? Imatinib will give you edema, GI intolerance, DASA pleural effusion, cardiovascular events, also GI tract. I'm not putting here. So maybe this will be less relevant for asciminib, and the balance will go to using asciminib. In case 1, imatinib is not better again. In case 2, dazabos or asciminib would be good choices. Imatinib, not necessarily. It could be a good choice, but if you're thinking about everything, then you have to think that the asciminib would be a good choice. What about the cost and affordability? Imatinib generics worldwide have lost the cost. Daza generic worldwide has lowered the cost. Also, Nilo generic less widely available. Bosu doesn't have, but for all of these are, less expensive than asciminib. So asciminib has a high cost that could limit availability. For case 1, she's in a private sector. She's very young. Any TKI will do, including asciminib. For case 2, is in a public setting. Asciminib will be limited in most public settings, at least in LA. I don't know in the rest of the world. So at the end, I think imatinib is still not the best frontline therapy. At least if the cost and availability will allow to treat with better drugs. That's my point.
Thank you very much, Virginia. Some excellent arguments there. It does sound as if the balance isn't quite so clear. Beppe, would you please share your slides? And of course, as I said at the start, this presentation was intended to be given by Professor Tim Hughes, who became unavailable due to flight disruptions. We're very grateful to Beppe for standing in. Beppe, the floor is yours.
Okay, can you hear me?
Perfectly.
Okay. Oh, perfect. So I'm very honored to substitute Professor Tim Hughes in this presentation. Indeed, I'm presenting the slide that he has indeed prepared, and I'm continuing what Virginia has previously said. So I think that what is important is I cannot move my slide. Okay, I can almost entirely remember the slides, but unfortunately I cannot see them unless that I'm going out. I'm trying to going out from and to reconnect again. Sorry for, but the concept that indeed was already presented by Virginia in one of the first slides is the underlining the same experience that has been done also in the SND about the Australian group. And indeed, one of the aspects that is very important is that there are two factors which are telling us I would say, which are the probability for a patient to achieve later on a TFR. Certainly, one is the fact that to achieve a deep molecular, fast molecular response, and this is achieved more frequently with second-generation TKI with respect to imatinib. We are speaking about the second-generation TKIs because it's true what Ehab previously said about the cost of asciminib. But between imatinib and asciminib, we have intermediate players that are second-generation TKIs, which are indeed a little bit more expensive than imatinib, but not as expensive as asciminib. And therefore, we have to consider now this drug as potentially players for the first-line therapy of CML patients with all the pro and the disadvantages that have been underlined previously by all of you. I would say that, however, apart from the fact that indeed the deeper molecular response is achieved in a very short period of time with second-generation TKI, this is particularly evident after only 6 years from the start of the therapy because, of course, later on, we know that even the percentage of patients treated with imatinib may increase the eligibility to TFR, but of course we want to obtain a response in a rather short period of time. And this, as you may see here, is in the slides is that is more easily to be achieved with second generation TKIs than with imatinib. This is the first point. Another point, which has been particularly due to the work done by the Australian group, is the fact that the patients who are responding very fast with a rapid drop of the BCR-ABL are those who are the best candidates to have, I would say, successful TFR. And this is calculated in Australia using the halving time. Halving time means in how many days from the start of the therapy you are halving the BCR-ABL percentage that is present at diagnosis. And this is, I would say, if this is less than 14 or even better, of 9 days approximately, this corresponds to the possibility of achieving very good, as you have seen even also before, very fast period of time, MR 4.5, and then to have the possibility, therefore, to the eligibility to try to discontinue the TKI therapy. And so this is very, very important to be considered, because from the biological point of view, it means that indeed we have with the second generation TKIs a faster achievement of the, particularly in the patients, and faster achievement of halving time, and therefore a lower amount of BCR-ABL, which is corresponding to probably to the fact that there is the clone, the pH positive clone is less complicated, is constituted but less subclones. Probably there are less mutations, not only BCR-ABL mutations, but also mutations in other genes that we know may play a role, like XLX1 and so on. So these are all points to be absolutely investigated, further investigated and ascertained. But for sure, indeed, the halving time is probably the best indicator that we have at the moment to indicate or to let us know which are the best candidates for a successful TFR, treatment-free remission. And we know that the halving time is definitely lower, even with a little bit higher doses of imatinib, but we know that patients cannot tolerate so well higher doses than 400 milligrams, but definitely lower with both second generation TKI and nilotinib with dasatinib, and is even lower, and this is of course a hope for the future, with asciminib. So this is something that is telling how important is indeed start with a stronger TK inhibitor rather than using a well-tolerated by a milder TK inhibitor like imatinib. And the second point is that it's true that we have a price to pay using second generation TKI. We know in particular pleural effusion for dasatinib, as well as cardiovascular events for nilotinib, as shown before. But it's also true that the person who want to achieve TFR are those patients who are young and therefore with less risk, like hypertension, like diabetes, and so on, which can contribute to the increased toxicity of second generation TKIs. Having said so, the second part of the slide relates to a very important question. It's an Italian study, and the Italian study is called Sustream, has been published on leukemia some months ago in 2025, and it tells us and it answers to an important question. If we are, for certain reasons, for many reasons, to oblige to start with imatinib instead of using second generation TKIs, in this case nilotinib, can we switching later on for the patients who have not optimal response to imatinib, and can we, let's say, recuperate, rescue what we have lost by not starting immediately with second generation TKIs. So more than 400 patients were randomized to receive nilotinib as first-line therapy or imatinib with I would say, in the trial, the possibility for these patients who were started with imatinib to switch to nilotinib in case of a non-optimal response. And according to the European Leukemia Net of 2013, not the present one, so the classical one that we know very well and we were using in the past years. And the response tells us no. If we are considering one of the primary endpoints of the study, which was the number of the patients who were achieving a very deep molecular response that as MR 4.5 after only 2 years of therapy, there is a statistical difference between those who were starting with the nilotinib with respect to those who were starting with imatinib and subsequently switching to nilotinib. But what is even more important that after 2 years of a stable deep molecular response, the patients were allowed to stop the TKI therapy and to enter the TFR. And what is relevant at this point that the first of all is a general consideration. The rate of TFR is quite high. Is altogether is more than 60%, around 60%. But if we are considering those who were starting with nilotinib with respect to those who were starting with imatinib and maybe subsequently switching to nilotinib, the difference is probability of remaining in TFR is really different. So it's statistically different between those who were between nilotinib and between imatinib. Was not a statistical difference between those who were continuing imatinib and those who were switching from imatinib to nilotinib, which are represented approximately 40% of this cohort of patients. So having said so, and on one slide that is the major advantage that we have seen is an advantage for the low-risk patients rather than the high-risk patients or intermediate-risk patients, which in Italian population, fortunately enough, represent approximately 2/3 of our CML population. Probably in Latin America, the percentage of the intermediate high-risk patients a little bit higher with respect to what in Italy, but the younger age and so on is telling us that probably this is the therapy to be used in countries. And I would say the advantage in these cases of discontinuing the TKI therapy with respect of the cost is certainly more, I would say, more than affordable. This is my personal opinion. Sorry, I'm not able at the moment to see the slides, so I was going through what I remembered of the sequence of the slide, but unfortunately there is this block that I will try now to solve. Thank you very much for your attention.
Thank you very much, Beppe. That was grace under pressure there. And given that they weren't your slides to start with, I'm amazed that you were able to run through them quite so fluidly. That was wonderful. And thanks so much, Nicola, for stepping in and showing the slides. So indeed, thank you very much, Virginia and Beppe, and before them, Katia and Ehab. So having heard both sides of the argument being put so eloquently, maybe Ehab and Katia, would you like to start with some questions or points of discussion that you'd like to put to Beppe and Virginia?
Yeah, would like to start?
Please, Katia.
Go ahead, Katia.
Yes, Beppe, I'm asking a question for Beppe. In the sustaining trial, I think it was the first study that demonstrated a higher TFR rate for second generation TKI. Am I right? Is he frozen?
Yeah, he's frozen.
Yeah.
I think he's tried to go out and come back in. Yes, it's come to questions. He's gone.
Got it. I'm done.
Virginia, are you able to take Bepe's question, or?
Oh, no, that's from the Italian group. I wouldn't, but I think it is. I think it is.
Well, so I'm going to ask
I would like
Virginia.
to add. I would like to add to the Katia's question. I was at the presentation at ASH of that study. Dr. Pane presented it, and it was quite interesting because there are no studies. The study here, they switched early in any patient who was not, and even though what I understand is that they could not rescue those patients who had started imatinib. They were not able to have the same benefit as those who had started with nilotinib, and that had not been shown in any other study.
Yes.
I think it is a very interesting study, and it also showed this benefit for low-risk patients, and we are always saying that those patients can do well on imatinib, but if we want to pursue TFR, this study is showing that it's not the best option. Thank you.
Yeah,
Thank you,
exactly what
Anna.
the study is saying is that if you start with imatinib, you lost that first rapid response, which predicts TFR.
But I think if I remember right, there was no difference in the high risk. Is that correct?
I can't recall.
Like,
I'm not sure.
Yeah, I think
Yeah.
there was no difference in the high risk.
I think the higher
it kind of
benefit
like
was the
flips
low
the-
SOCO.
Right, so it kind of flips things upside down,
Oh.
right, for our recommendation for the second gen.
I think there was a difference in the high risk, but and we would expect not to have the same difference in the low, but here they showed that the low also, but we could check it.
Yeah, I honestly can't remember.
Yeah, we have to check
And then
it.
there was no discussion on the cardiovascular side effects also, right? Or did they present the cardiovascular side effects?
No, they didn't present. I watched. I don't remember. I watched the session.
That's 20% or like 10% versus much lower cardiovascular side effects. So I think I would rather take a pill and stay on it as opposed to have no pill and have a stroke and a heart attack.
They did show. Let me see.
Welcome back, Bepe.
No, but against that, look, what we have shown and again is that patients that start with imatinib, they will end up having the other pill, which heightens the rate of heart attack and cardiovascular events, and you lose the possibility to do TFR. So it's you win some things, but you also lose the possibility to go to TFR. You would end up in 70% of the cases being changed to that drug and without having the advantage of having TFR in most cases, because once you change, because you don't achieve the goals or whatever, you will be exposed to that second generation. Equally, you will have the effects of the second generation TKIs eventually. So why don't we try to do it earlier and gain the TFR advantage, and then more patients will discontinue, as it was shown here, and it has been shown before also in other trials. Please, Bepe, come back.
Yeah, okay. I'm
He
back.
lost the beginning.
I
We're
agree
asking
that
about
this
the Susterni trial.
Yes. There.
Wait, there's something, and I shared something. Well,
Yes,
there's no difference
that
in the cardiovascular side effect. That is a first. in the world that nilotinib was as safe as imatinib.
Well, they say
Right?
we are supposed to know more how to manage those patients and be more proactive in the prevention. Who knows?
Yes, absolutely. Then there has been an interesting study, sorry to intervene, just a proposition which was made by Jacob Kantajan recently, European Leukemia Net meeting, that it would be possible to see for the patients among the, I would say, thousands of patients who are treated in the world with nilotinib. Indeed, if there are some patients who are taking already aspirin or some anti-aggregation and compounds, and to see if they have the same rate. Indeed, we have done very little during all these years about how to prevent the appearance of cardiovascular events, even in terms of quality of life and so on. We have just generally are factors which are very difficult to control. I would say like diet, hypertension. Hypertension is easy to control, but not all patients are indeed, I would say, they wanted to control it and so on. So I think that it's important, however, just to study better the problem of the cardiovascular events. Then there is now, I would say, a launch, I do not know if it's a launch, of a new type of nilotinib, which is a different salt. I cannot remember the different at the moment, which apparently has less cardiovascular toxicity with respect to the traditional salt that we are using with nilotinib. So there are several reasons to believe that something which is probably not so expensive like a shimimib, but I would say almost equally effective, can be used for particularly even for the country which are not allowing the use of shimimib as first line for all patients. There are a few countries now. I think the United States is one, but is related, and Germany is also totally free. In Italy, we are still waiting the approval, but probably it will be free also the use of ashimimab, but it's a huge cost for the health system.
On the subject of alternatives, I might just have a look at a question that's come, or comment that's come up from Carla Bocampani from Brazil in the chat. She says, congratulations on the presentation. About generics, there are many bad quality generics. This could compromise the response in first line. And apart from being cheaper, perhaps could lead more patients to fail. How do you feel about that? We might start with Virginia.
Yeah, that's the reality for our, again, especially for imatinib, that there's a lot of brands, at least in Colombia. We have been changing brands, and that not I don't think it's they're very, the responses might be the same sometimes, but the toxicity is higher with these new brands of generic imatinib, which end up having ending up in changing of lines again and losing that good, a good response, early response, because you lose the response, you have to change drugs, and then you lose again. And at least in Latin America, this is a very good problem, a very big problem. I don't know if you have seen it, Katia, also in Brazil.
Yes, in Brazil, we stayed many years. It's only two types of generic, and in the first analysis we did, it looks like the same. It was not statistically different. But now what we have seen is that there's a lot of other generics there were not evaluated, and honestly, we don't have data about that. The others that are coming. So I think that's something that we have to be aware and to be concerned to be vigilant when you. And now in Brazil, for example, we have a dasatinib generic that we still don't know how it will be compared to the brand.
In Italy, the experience with dasatinib generic is not totally favorable. It has been reported, for example, USA. It depends also on the type of the company which is producing it and so on. So I think this is a problem for the future years because there are several types, as mentioned, there are several types of generics and not all of them are good. And
Yes,
so
yes, you're
we
right.
must be very careful. I think that one of the solution for this, I do not know why, because the bigger company like Novartis and other companies like BMS and so on, they are no more interested in the drug which have become lost the patent. But I would say that even if their cost is a little bit higher, probably they should continue to produce the drug at an accessible price, even after the patent. I do not know. I do not know the reason why. I would say companies like Novartis, who has also, I would say Sandoz is a good pharma company who can provide also generic, cannot provide the original imatinib as generic. I cannot commercialize the original imatinib as generic without the need just to change continuously the therapy, moving from one to the other, and so on. So I think this is something which is commercial, but probably has nothing to do with a good practice in medicine, I think.
Ehab, in your presentation, you or in preparing for it, you've done a lot of research into relative costings. Do you have similar problems in the USA? What do you think?
Not that I personally noticed or published that there's a difference in generics. I don't think we have. I don't believe, at least in my personal experience, that we have the same issue because people are being switched to generic without. I'm not even asked that they're being switched. I think another important point is for nilotinib and dasatinib is the dose, right? I really think nilotinib has been dosed higher all along, and that a lower dose is as effective and safe. So I think that also applies to asciminib. We all have used dasatinib at 20 milligram, and it works. So I think there's a lot to be told in terms of the safety of a lower dose of those drugs. And
I totally
Carla,
agree
I
with
thought
you.
you were my friend and on my side. I can't believe that you're not on my Katia and our side. I can't believe you're asking a question that would go against me and Katia. But you know what, Carla? You'll pay for that.
Carla, would you like to comment?
Thank you
Not
so
on the
much.
retribution.
Don't be shy, Carla.
Now we have many problems in the private system in Brazil about the generics. In the public systems, okay, it's not a problem for us, but in private system, because the private system needs to pay cheaper. Then we have many Indians labels, then this is a great problem for us. Then we are seeing in the private system many patients with many adverse events, is okay, like Virginia, but now I am seeing many patients losing the response. Then my question is about the using generic. More patients will lose the response, and after they will need to switch to other drugs, second generation, and then more patients are needing to third line. Then perhaps many patients in this way will perhaps many patients going to blast crisis or losing the response and losing the chance to TFR. Do you understand?
Yeah.
I agree.
If it's a concern, of course, like you're saying, going from one to the other, that's a big problem. Yes, Carl.
Yeah, I think the ideal treatment the ideal treatment would be the perfect one that you don't have to change, that you don't have fewer side effects, and at long term you have you have a good survival independent or not stopping treatment. But as I mentioned in my presentation, no drug is perfect. You have some kind of type of side effects using one or other, one of them more, other less. But I think something that we have to handle and to try to choose the best for the individual patient that you are treating.
So,
but it's very important that what Dept mentioned about the velocity of the halving time. This is very important in terms of biological behavior
Yeah,
of asymmetry. The rapid
absolutely.
response, this justifies it's related to the chance of achieving TFR. This is a very important data.
Yes, I think that it's what is mentioned that there is a number. This is telling us one main message, I think, that there are patients in which probably we can obtain sooner or later TFR, independently from the TKI that we are using, and this may be faster with second generation TKI, longer time to wait for Imatinib, but probably this is what will happen, and other patients will not be able using simply TKI just to obtain a stable or durable TFR, probably because they have a more complex structure of the pH positive clone, and therefore it's quite difficult to overcome this form of resistance, because also the fact that not able to achieve TFR is a form of resistance, if you want, of the clone towards the TKI therapy. And the only probability probably in the future will be to address at this point using drugs different from TKI, because otherwise we will not be able to achieve a TFR, at least in the vast majority of our patients. There will always be something like 20% of the patients who are not achieving TFR, not be able to achieve TFR.
Yeah, I mean, it's only a small, like, I think, Beppy, like, my mind is, yes, TFR is really important, but I think to patients too, when we keep talking about TFR, and most patients will not achieve TFR, like 70 to 80% will not achieve TFR. So patients actually feel like they're a failure or they're bad. So it's kind of like a balance there. And what I'm trying to do, and we're all trying to do, is like kind of almost like the radiation ALARA principle, which is as low as reasonably achievable, right? So at the end of the day, 70 to 80% will need to continue. So our goal, yes, TFR is important, but it's only a small number of patients. But our ultimate goal should be the lowest. Maybe one of our ultimate goals to be the lowest achievable dose for these patients, and just accept that they will be on it.
I totally agree with you. I think that this is the moment. Of course, the problem of overall survival is almost completely solved, I would say, because the overall survival is similar, not perfectly equal, because we know that there are still patients who are dying of CML. Not a huge percentage, but however, there are still some patients who are dying because of progression of CML. But I would say the problem of the selection to try to push for TFR or not, in my opinion, is mainly due to the fact that of the age of the patient, and of course of the comorbidities of the general condition of the patients. It's a CML in the young patients is the only problem. I think that we have to try to achieve a stable TFR. Whereas if it's an elderly patient with many other problems and so on, one additional pills at the lower possible dosage, well tolerated, will be the solution. I totally agree with you. But the problem is that
And then
the TKI
no,
therapy can never be discontinued, because this is absolutely the basis of the CML therapy.
Before
I have a
you go
question on
on,
the
Ehab,
survival.
I'll just before you go on,
We
Ehab,
don't have that time.
no, we're fine. But just in the chat, Patricia Espinoza is reiterating the importance of of studies, and also the issue about low cost and ineffective generics is being raised there as well. So, Carla, you've hit a good discussion point there. Sorry to interrupt you, Ehab. Please go ahead.
Now, I was going to bring up the survival point. So, to my knowledge, we have the Swedish registry data that showed survival was very similar. And then we also have the US SEER data. The US SEER data by Tom Radvojevic actually shows that patients with CML have almost double the mortality compared to the general population. What other studies, and I'm truly asking, do we have any other studies that have evaluated survival in patients with CML? Like, does Brazil have studies? Does Italy have studies looking at CML versus no CML?
No, it's something that we want to do. But what we know that in the CML population, I would say the person who are dying because of CML are altogether, I would say, a minimal percentage of those who are dying. The patients are dying because of other aspects, and you can say, okay, toxicity related to the therapy. This can be one other probability of dying, which is not directly due to CML, but indirectly due to CML. And this is true, but we need more data about this aspect. However, the real problem is I would say the real solution will be to get rid of the disease, particularly for younger patients. I think that the median age of the population in Latin America is how much? It's 40 years, something like
No,
this.
no, it's
50,
higher.
50,
It's 48
54.
to 49.
In
For
Brazil,
48,
Colombia,
49.
54.
In Italy is 62, I think, nowadays, so at least 15 years older. So I would say that for a younger population, which means the median age means that we needed to push for TFR, absolutely. I think that the ages and the comorbidities are the major determinants in selecting the goal that we want to achieve. Otherwise, I would say it's not good for a person who is 30 or 40 years old to continue to live for the rest of his life with the CML, even because certainly there will be, I would say, probably the overall survival of these patients will not be as good as the one of these comparable persons in the general population.
Yeah, regarding your question about the survival and the general population, we have made research with our patients. We have a registry in Colombia. We have almost 2,000 patients registered, and we did an analysis of we published an analysis of almost 1,000 patients during 20 years, and we also we divided by years. And the mortality in our cohort of patients through years were exactly the same as the Colombian population, the general population. When you use it, you compare it with the age and with the years. You know, for example, in 2020 with the pandemic, the mortality raised exactly equally than it did with the general population, and then went down again equally. It's exactly the same. And then when we compare for the age zones, the age ranges, it's exactly the same for Colombian general population, what's reported in the general population that's reported for Colombian patients. So that's, I know there's more than this information, but the mortality, as Katia showed, the overall survival is the same with the three TKIs we analyzed, Imatinib, Dasatinib, and Nilotinib in first line, because we didn't have Bosu in first line in Colombia. So for our analysis, the thing is that the patients change. Almost 70% of the patients with Imatinib in first line end up changing, lines. I know there's an overrepresentation of that because as it represents like 20 years of practice, you will know we were not so smart at the beginning. We changed people earlier. But even though most patients with imatinib at first line end up changing lines. So
This
even
is
if
an
the oral
interesting.
survival is the same, yeah.
It's the same in our population to 40% change by side effects, by resistance, and then you have to go to a second generation.
Yeah, so you will get exposed to the same toxicities as if you start earlier, but then you won't be able to go to TFR. That's our point. Also, we have been, changing a lot to second generation, not only looking for TFR, but also because we have, and in Latin America, that's a lot of problem, that because we have a lot of Imatinib brands, that's another thing that end up, pushing us to change.
Yeah. I would like to ask to Ehab. You said that the mortality, however, in CML patients is almost as double with respect to that of the general population in your analysis.
In the US, your data, yes. Radovojevic, I can send you that paper. The mortality for patients with CML remains higher than the general population in the US.
Yeah.
And we don't know why. We don't know the comorbidities or what is it.
Do you
Yes,
think
no, I
there
think
is
it's
a part of
important.
population with no treatment? Do you think there is some part of these patients that are not, the monitoring is not good and the treatment is not covered, the patient stops taking the treatment? You don't know the reason
No,
about that?
it's important, however, with respect to what Virginia was saying. I think that what is important is to know why the patients are dying. The median I would say the median or the life expectancy in the United States probably is higher with respect to what we have in Colombia. So the difference that you see in, would say, in the States can be seen because the life expectancy of the general population without CML is higher with respect to that of the CML patients. Whereas this difference is not seen in Colombia because people of the general population are dying of other causes with respect. So are rather complicated studies. It's not so easy to be done, in my opinion. This is
Yeah.
That's true. That is true.
If you can share that paper with us, though, we can circulate that along with other papers to the general audience, along with the ASH abstract that was discussed earlier. That's easy to share.
Ehab, one thing, Patricia Espinosa is, asking about those economic analysis you talked about, because they're trying to introduce generics in Costa Rica, from what she's saying. So it would be nice for her to have it if you can share it.
Sure, Patricia. Just remember that these calculations, the ICER is kind of an official calculation. The TFR, kind of an Atallah calculation, which it's accurate, but all of these calculations don't take into account, for example, how many times it's more complicated than just the cost of the drug, because it doesn't take into account, like, let's assume for a second that asciminib is safer. So therefore, if it's safer, people go to the hospital less, so the cost is less. So we just need to be aware of that. I'll share my slides, of course, but just to be aware of that. It's much more complicated than what I presented. It's a lot more complicated than that, of course.
So looking at the time, we might go to all of our experts for some closing comments, final thoughts, reflections on the proposition. Why don't we start with Katia?
Well, thank you, everybody, for this important debate. I think in my conclusion, analyzing everybody's opinion, I think we all agree that we now have more potent drugs than imatinib that are able to give us a higher rate of major molecular response, a higher rate of achieving MR 4.5, but we still have some issues about toxicity. So to choose the first line, you have to take all this in consideration. And of course, the cost is always a barrier for using more potent drugs. And that's my final conclusion about our discussion.
Ehab.
I think these discussions are very important. Like I showed in my second slide, we are really in an embarrassment of riches. We have a lot of drugs, and we have more drugs being developed. At the end of the day, each patient is unique, and 40–50% of patients will end up switching at some point. And that's the benefit of having CML specialists, because we can work with the patients on identifying what's best for each patient.
Thanks, Ehab. Virginia, what would your final closing comments be?
Yeah, I think we all agree, and what we want to do is have more patients in TFR, but with that rational cost in terms of toxicity and cost, of course. I think we're really early in asciminib history to know Ehab is right that we don't have long-term studies. We don't have TFR studies for that. So we're just dreaming here that we can have this wonderful drug and at an affordable price. And I think we will have this discussion, for many, many years to come as we know more data on that. But it's nice to, at least have all these possibilities.
Beppe?
Yes, I will now share finally one of my slides, if it's possible. But
Yes,
is the final message that Tim Hughes presented in his slide, and I do not know where to share now. It's complicated today. Everything is complicated, misses the time and so on. However, I can read even this now. Imatinib is the only best choice where it is financially necessary or where the toxicity price of a better TKI is too high. I think that this is probably a message that probably is true. Imatinib is still a champion, is saving a lot of life in the world and so on. There is something better, particularly in terms of TFR, not in terms of overall for the CML patients. And we have to keep in our way that the research on CML has to continue just to achieve sooner or later a definitive cure of the disease. Thank you very much.
Thank you all. Thank you very much, Professor Ehab Atallah, Professor Beppe Saglio, Dr. Katia Pagnano, and Dr. Virginia Abello Polo. And thank you very much to our audience too. If you have questions and follow-ups from today, please get in touch with me and I'll get a response from you ASAP. We are very well connected, as you can see. Now, Beppe wasn't the only one having problems sharing slides today, but let me see if I can get back to my own slides. Can you see that?
Yes.
yes.
Okay, so excellent. I can't see any of you, but as long as you can see my slides, we hope to see you again. The next Latin American discussion will take place on Thursday, the 21st of May, same times as today, and we'll get a great team of experts for you then. Please join us for it. The third meeting of this series is scheduled for Thursday, the 2nd of July, where we will go back to the CML laboratory and ask how to get the best out of it when resources are limited. And we hope to see you online too. We have a new website, so please go and check it out. Sign up for ways to keep up to date with all the CML news via the newsletter. We can send you papers of the month, keep you up to date with upcoming meetings, webinars, links to our summaries and discussions. Also on the website, you can engage with our interactive case discussion forum, where we take difficult or interesting cases to key experts in the field for advice or commentary. If you aren't already familiar with the ICMLF Knowledge Center, please go and have a look. There is a wealth of knowledge there with many dedicated modules and a new major new module, Next Steps in CML Management, currently in development with initial releases in sight. Or you might like to join some of our social media outlets, Facebook, Instagram, X, formerly known as Twitter, whatever you prefer to engage with. Yes, if you have any cases or questions not answered today, please get in touch with me and I will get a response for you. Okay, that's it for me. Thank you, gracias y obrigado. I hope to see you all again on 21 May.